neuron activity throughout the cerebral cortex. And what this does is when they have this abnormal discharge, normal behavior can't happen. So it's just a dysfunction. Now, in a lot of cases, the abnormal brain stimulation results in some kind of funky, generalized motor activity. And we may see it, flailing about, rigidity, rhythmic movements, things like that. And some other times, this motor activity may be localized. So it may be more of like a behavioral change or something like that, as opposed to the big, what we kind of think of it like tonic-clonic flopping around, things like that. So there's a lot of different things that can cause seizures, but most of them are what we call idiopathic, which means we don't know what causes them. They're undetermined. All right, and then it's diagnosed as epilepsy. Now, there are some things very specific that can cause seizures, like toxins, different drugs, metabolic disturbances, especially your electrolyte imbalances, and hypoglycemia. Fevers, especially in pediatrics, febrile seizures are fairly common. Trauma, strokes, tumors, all kinds of things can cause seizures. So, with this, a key piece of information here is going to be whether or not they have a history of seizures. A new seizure means something substantial usually has changed there. So a doctor is going to try to establish whether this is a new onset or not, to see if there could be some kind of life-threatening cause, like a cerebral hemorrhage or brain tumor or something like that, versus more benign causation there. Now, we have two major classifications, with each one of them having some subtypes there. Your generalized seizures are going to be like your tonic-clonic and absent seizures, and your tonic-clonic seizures are motor seizures involving the entire body. So they're going to start with like this hypertonic state of muscles where the body's very rigid, and then you get the clonic phase, which there's these rapid rhythmic contractions of the muscles. These are kind of what most people, when they hear seizure, this is what most people think about. And then after the seizure, it's going to have a postictal state, and this is where the brain's recovering. It's tired. The body just used a whole lot of energy in a very small amount of time. Right? So you will have this postictal state. Your absent seizures are more common in pediatrics than adults, and usually involve a loss of awareness but no change in your muscle tone or activity. So they may just be talking and all of a sudden just seem like they pause out real quick and they just kind of checked out. They may even seem like they're daydreaming or something. And in fact, a lot of kids get diagnosed with this because they were recommended for further evaluation for, say, ADD or something like that, because they seemed like they were daydreaming. Now, your partial seizures are going to be focal or localized to one area of the brain, as opposed to being generalized across the entire brain. Now, these partial seizures can be simple or complex. Your simple partial seizures can include some aspect of motor, sensory, or autonomic phenomenon, but these patients maintain consciousness unless there is some kind of secondary general seizure activity in the brain as well. Now, your complex partial seizures may have some kind of aura, and may involve some kind of impairment of awareness, and have some kind of specific moving, like stair stepping, like their legs are moving, like they're climbing stairs or something like that. And as far as the aura, that may be a smell, like hearing something, seeing, visual disturbances, things like that. These complex partial seizures are usually also accompanied by a postictal phase. And sometimes these may even come in as like kind of a behavioral emergency type thing there. Alright, now with our postictal phase, usually we get on scene and people are no longer having an active seizure. Okay, so they're in this postictal state and they have some impairment of mental status. Okay, they have some sort of impairment. They may be unresponsive, they may be awake but confused and slow to respond to questions. And they may be sleepy for several hours following that seizure. An important thing to keep in mind here, with our seizures, one of the most important things is that these patients can become injured during the seizure. They can become hypoxic and they can become acidotic. And they may have some sort of airway obstruction during that postictal phase. So lots of oral secretions are fairly common because they're unable to swallow or clear their airway when they are seizing. So they may require suctioning, and they'll often require at minimum positioning in that recovery position to allow for some of those secretions to drain out. They may have some blood in this secretions if they bit their tongue or their soft tissues during that seizure. So we're going to use our manual airway maneuvers to maintain that open airway. And if some kind of adjunct is required, usually they'll tolerate an MPA better than an OPA. Okay, if you suspect there was any kind of trauma involved with the seizure, like they fall from a height with the seizure or something like that, consider C-spine if it is needed. A lot of times your post-ictal patients will have a slightly increased ventilatory rate, but if those ventilations are inadequate, assist with your BVM, okay? If their ventilations are adequate, give them oxygen in the immediate post-ictal period because those ventilations may have been impaired during a seizure, and control any major bleeding that you note. We're going to assess our patient for any injuries or indications or other abnormalities. We're going to get as much information from witnesses or family members, including a description of the seizure activity and how long it lasted. We're going to get our full sets of vital signs. Okay? We're going to get blood glucose level. Check a sugar, check a sugar, check a sugar. All right? They may use up all of their sugar, their available glucose during a period of seizure, but also hypoglycemia can cause seizures. All right? Find out if they have a history of seizures, if they've had any history of recent trauma. Find out any medications that the patient's taking, and don't forget to check any medical alert jewelry or apps on their phones or things like that. Now your protocols may vary, but they may require that you start an IV in a patient who's suffered a seizure. If you can get one, it's usually a good idea because if they have a subsequent seizure, then you've got a route for medication administration. Post-ictal period can last up to 30 minutes before they can even answer questions appropriately. It may be shorter, it may be a little longer. These patients who've had a seizure, especially if they have a history of seizures, may refuse transport to the hospital. And so this is kind of a dilemma for us because, if let's say they have a known history of seizures and let's say their level of anticonvulsant medication is a little bit lower than the level they need. All right, that's the most common cause of a life-threatening condition called status epilepticus, okay, is inadequate levels of anticonvulsant medication. But even in patients who are taking their medications directed, seizures can still happen. Sometimes they happen, and usually they occur without consequence, and they may not need or want medical assistance. Usually what happens here is the seizures occur in the presence of somebody who's not familiar with it, and it looks very dramatic, and so they call 911. As with any patient who refuses treatment and transport, assess their competence to make decisions. Okay, simply because the patient had a seizure is not sufficient reason to assume that they are unable to make their own decisions. Make sure that you try to figure out why they don't want to go to the hospital, inform them of the potential risk, and if at all possible, ensure they're not going to be left alone. And then follow your local protocols for contacting medical control and refusals as needed. Now your status, tonic-clonic seizure that lasts more than 5 minutes, or consecutive seizures without a period of consciousness. So it's like seizure, post-ictal, seizure, post-ictal, seizure, post-ictal, and they never come out of that post-ictal phase. That is a life-threatening emergency. So you're going to request a paramedic response. We're going to transport without delay to the closest emergency department. Then we're going to manage that airway and their ventilations. Okay, probably not going to be able to do an OPA or advanced airway because of that seizure activity. So we want to make sure we use an MPA if possible and BVM to help manage that airway, because while they're seizing, they're not managing their airway appropriately. We're going to start an IV safely and check their blood glucose level. Okay, contact your med control about fluid administration because rhabdomyolysis can occur sometimes in status, so IV fluids may be beneficial there. We're not going to put a bite block or anything else between their teeth to try to prevent them from biting their tongue. We're going to move objects away from the patient, place any kind of padding beneath their head to protect it if they're on a hard surface. Now, in sudden unexpected death in epilepsy, this occurs very rarely, but it occurs in less than 1% of patients who have epilepsy. And what happens is these patients whose seizures are uncontrolled are at a higher risk than those who are well controlled. It does not happen during a seizure, but may occur shortly afterwards, and so it may be unwitnessed. The autopsy findings associated with this usually include cerebral edema and hypoxia in the area of the hippocampus, sclerosis of the amygdala, and the neurogenic pulmonary edema. So a couple different things there that kind of go into this, all right? But they're not really 100% sure, but they think some obstructive apnea and cardiac dysrhythmias that go along with your hypoxia may be implicated in it.